Good evening, everyone. I'm Dr. Keyur, a student of Sandeep Gore, sir, and I will just try to talk about the newer concepts of trauma resuscitation. I actually quite keen about trauma as well as resuscitation area because we see lotions over here. So let me show you my whatever knowledge I have. Trauma is a eighth leading cause of death in India, largest cause of death between 5 to 29 years. This is a bigger trouble, 5 to 29, where the young people, the patients who are dependent, families dependent on this patient. So this is a big trouble. Annually, about 1.5 lakh people die due to trauma. About 4.5 to 5 lakh people are injured annually. I suppose this is a less number because, in fact, we get daily about 8 to 10 patients. So I'm not sure how far this is a true, but it's there. Good part, it is preventable. Bad part, people are still not doing the job. Government is doing the job. People hate that part. Anyways, we can't do it. But whatever we can do in our life, being an emergency physician, so that will help the patient. So know about the new concepts, what is coming up. I still think that we need to know the previous history as well, that how this emergency medicine things have developed. So I would like to divide this topic into three: pre-hospital service, preparation to receive trauma patients, and the use of beds and artificial intelligence. So talking about casualty transport, yes, I know we all hate this word as casualty, but initially this is how it started. So thanks to Dominique Jean Larry, he was a French surgeon and a military doctor. He was an important innovator in battlefield medicine and triage. He often he is often considered as the first modern military surgeon. He used this ambulance. He used to treat at the scene. He used to triage patients at the scene, and then he used to transport these patients in this wallet. Now, the point is, in the 7th century and the century, they had understood all this. Still, it is how far it has taken time to develop. We'll just go through. But over what we have learned, the trauma part was majorly learned, or the development was been seen during the World Wars and the war system. So for this casualty transport, there was an importance of minimizing the time lag was noticed between the initial surgery and the early reconstructive procedures, which was initiated from the field trauma center. Field trauma center is a word where there is a war going on. There is an area where all the uh, our military personnel have been affected. They have been brought over there. So that stage, it was so difficult that patients used to the army person used to stay there, and then once the war is over, after that they have been transferred, which led to more complications. So all these things when it they learned, so they had coined this word called as golden period, which described the importance of a time lag between the wound and the initial surgery. Then I would really thank Dr. R. Adam Cowley, who coined the word golden hour. From the golden, then we went to golden hour. In this golden hour, this we understood this when Dr. Lee explained about the trimodal distribution of the trauma. Here, if I am trying to show that there are three deaths which can occur. One is immediate, second is early, third is late. Immediate death, not much could be done. Early death, that was what people had realized. Okay, this death could have been saved if timely patient receives a proper management, proper treatment, and deaths could be avoided. Late deaths, again, post 2 weeks to 6 weeks, that is still not in our hand. Here, we also came to know that there is a golden hour between life and death. If you are critically injured, you have 60 minutes to survive. You might not die right then. It may be 3 days or 2 weeks later, but something has happened to your body that is irreparable. So this golden 1 hour was really been understood well by all of us. And from golden 1 hour, they transport system, they also learned in 19th century, maybe in the 1990s to 2000, that most of the golden hour is pre-hospital event. There are multiple studies which show that on average it takes 35 to 45 minutes from the patient who met with an accident or there was a call to the arrival at the hospital. So thus ambulance services had been introduced. Support was not enough. So we brought ambulance with paramedics. Again, they understood that just staying with paramedics is not okay. So they in 2017 we realized that okay, we require a three-person team, which is a physician and a paramedic team. And here we understood about the platinum minute. That is the first 15 minutes are utmost important. So this helicopter transport system was been brought up, and within few minutes we reach to the patient, we give treatment, we shift, and then we bring this patient back to trauma. So thus the air ambulance with three-person team was introduced. So this was what I could talk about the pre-hospital. Now talking about the blood transfusion part. Blood transfusion part, what we learned was in between World War One and Two, where majorly the storage, blood storage was been learned, but we never understood what are the consequences related to it. So we used to give blood to the patient, the whole, but the whole blood system had ultimately related issues like trauma related issues, infection related issues were being notified, due to which the whole blood concept was been stopped and fluid had been, so the crystalloids were been given instead of whole. Now, initially again, we had no clue. So just to maintain blood pressure, we used to keep on giving lot of fluids. Then we realized, oh, giving crystalloids, too much of crystalloids is also a problem. So then we limited ourselves to 1 liter and permissive hypotension. This again was a debate which was going on, that crystalloids or blood. So I would just say that blood is what we need for a bleeding patient, and salt and water used for cooking pasta. This is what when we understood, and a newer concept had brought up, that is pre-hospital blood transfusion, REBOA and pragmatic. So this pre-hospital transfusion, they used to carry O positive and O negative blood, and depending upon that, they used to give. They notified that okay, if when we are giving blood in a, this is related to the curve and hypovolemic shock, hemorrhagic shock, not in all the patients, but here when there are stage 3 and 4 hemorrhagic shock, they noticed that okay, when we are giving blood, so there is a decrease in mortality. It was 34% with blood, and when we give blood in the ambulance, which showed decrease to 19%, which brought a good idea. Then again, storage was a problem. Here, pragmatic rule, the ratio which we have right is 1:1:1. It took a lot of time, lot of research, and ultimately, initially what we used to give, transfuse blood, plasma, and platelets at the ratio has been shifted to 1:1:1. What we achieved over here is good hemorrhagic control. That was the most important part. So due to this, we got a benefit. Now, there was again in 2013, REBOA was really a blessing. So I'll take some time for to explain about the REBOA. REBOA is resuscitative endovascular balloon occlusion of the aorta. So first, let us understand what are the indications for REBOA. So any area where we suspect intra-abdominal or pelvic bleeding. So these are the areas where we cannot compress the bleeding. Then any patients who are pulseless or profoundly, like they are in shock, not responding to our initial treatment, or they are transiently responding to fluids or blood. In such case, REBOA was really useful. Even in non-traumatic indications have been notified, that obstructive hemorrhage, which again we are seeing it regularly, maybe a day or two, we see 4 or 5 patients uh, each day, out of which one or two are postpartum hemorrhage or antepartum hemorrhage, and then we really need a lot of blood, and massive blood transfusions are always activated over here. Lower GI blade surgeries where massive hemorrhage was been expected. So what is this REBOA? So it's basically a balloon. It's a stent. It's a balloon which we inserted from the artery. The femoral artery, it passes the aorta. From this descending aorta, we divide this into 3 zones. First zone, that is called aortic, which is from the subclavian artery to the above. The second zone is in the celiac trunk to the lower renal artery. And the third one is below renal artery to bifurcation, to the aortic bifurcation. So REBOA 3 was much used at earlier stages. And over here, when you used to, so what was the problem? That, okay, if there is a bleeding, we obstruct this so that the heart and the other areas get the blood supply. And then in between, we used to reduce the pressure so that the blood is also flow to the limbs and the other area. But in recent prospective studies, there was no significant differences in overall mortality between patients undergoing resuscitative thoracotomies and those undergoing REBOA for non-compressible torso hemorrhage. Plus, there are also complications associated with these procedures, like excessive ischemia during aortic occlusion, post-operative thrombosis, limb amputation. These were there. Thus, we shifted our gear to CRASH 2, CRASH 3 trials. Well known to us as of now. We all gave tranexamic acid, but how did it happen? So the CRASH 2 trial, it was more for the upper abdominal as well as pelvic region and the limbs, where we thought, okay, it is better to give tranexamic acid, which is 1 gram over 10 minutes for the patient who met with an accident and coming to trauma within 3 hours. And then the second, we gave 1 gram over 8 hours as an infusion. Yes, there were limitations. Limitations were related to the we don't have any clue that loss occurred in hospital. It was difficult to measure. There were insight into mechanisms, actions of tranexamic acid in the bleeding trauma patients. But it did show that tranexamic acid has a uh, safety. It has reduced the risk of death trauma patients, majorly in the, again, uh, hemorrhagic stage 3 and 4. Similarly, CRASH 3 trials also concluded that yes, if we give this tranexamic acid drug within 3 hours to even a traumatic head injury patients, it is useful, though it has shown better results during mild and moderate injuries. Severe injuries were still not able to justify it. Now, the later they have brought this concept that, okay, shifting patients to trauma, like I'm working in a rural area, and most of the patients get initially shifted to a PHC, then a CHC, then they come to us. So there is a lot of time lag. So this concept had come up that if you suspect grade 3, grade 4 hemorrhagic shock, then let the paramedics give tranexamic acid IM. There has not been seen any adverse reactions, and then Hopefully, still this papers are still been getting published. Results are yet to be known, but they have started doing this. One more drastic difference which we came to know initially, whenever I had learned like polytrauma cases, what we knew patient who is hypotensive. So majorly this patient is bleeding somewhere in the thorax, or it would be abdomen, pelvis, or maybe bones, or he might have bled outside before coming to our hospital. But over here, a lot of papers have published and they showed that 13% of the cases where hypotension was noted and didn't had any other injuries other than head. So there was an isolated head injury in 13% of the cases, which contrasts the ATLS teaching that isolated traumatic brain injury will not cause shock. So finally, with this tranexamic acid, we are coming back to whole blood group and now with a lesser issues. This was well learned during Afghanistan-Iran war. So here the concept is that when I want to give blood and if I use 1:1:1 proportion, it is time consuming. It needs a lot of manpower, especially in military cases, it is quite difficult. So they again started with whole blood and they noted that there is a 570 ml. So here we need, there is a less dilution from that. Like the concept was we get a blood, we divide it into three. Then when we want to transfuse, we again go back. Rather, we give the whole blood. Now when we know about the cross match, about infection, so the lesser risk has been notified. Plus, the use of preservatives can be reduced. They also understood that, okay, if we do this, there are more platelets and more coagulative factors rather than dividing it and again giving it back. So now again, this newer concept has started of giving whole blood, but it will be a cross match. So lately now REBOA zone 1, which is from your subclavian artery to the above celiac trunk, tranexamic acid 2 grams IM, then ECMO. This is the latest what we are going through. And as we all know, Fortis is one of the hospital which has proved us that yes, we can do ECMO at our emergency department as well. Thanks to Sandeep sir for this. Because till date, lot of ICU people are doing it. And it was always said that it's an ICU work. But when it is all about life, when it is all about patient, we can do it and achieve it very well even in emergency medicine department. Coagulopathy, it's a big problem. So traumatic coagulopathy was thought primarily that it was due to fluid and hypothermia. Finally, over time, it concluded that it is not the fluid, it is the trauma itself which causes coagulopathy. So this new device called as ROTEM was been brought in around 2003 or so. So I'll just give some idea about ROTEM. So ROTEM is rotational thromboelastometry. It is a method of measuring hemostasis quality via viscoelastic properties of blood clot. In short, there are many patients where we are treating them. Few respond even to blood, small fluids, sometimes small amount of blood, and they're responding. And there are few who are not responding, no matter what we try. So here, this part that how is your strength of the clot matters. So they you give tranexamic acid, you do resuscitation, and if patient is still bleeding, we can use this devices. On the right side, what we can look at is a normal graph which talks about CT, that is a coagulation time, CFT, which is clot formation time, A5, which is the most important, that is at 5 minutes, how much amplitude has come up. So it indicates amplitude 5 minutes after coagulation time. MCF is maximum clot firmness, not so useful, at least what I feel. Maximum lysis is ml and Li is lysis index. So what it's a always a difficult to understand to explain, but in 4 or 5 slides I would try to explain. If a patient is bleeding, we have done all the jobs and still it has not worked. So we can use this device. In this, there are 3 steps. So the first step is about A5. So that is, they noted that in trauma, the first thing which gets depleted is a fibrinogen. Okay. So this fibrinogen level that in A5 is less than 10 mm. So this is how it looks. When it is less than 10 mm, as you see over here, this is 8 mm. So it was less than 10. Here, it is always better to give 10 to 20 ml per kg of cryo to this patient, and it's going to help. Okay, that is the first step. Now, maybe the first step is clear. The FIB TEM is more than 10 mm. So we'll go to the second. Now in second, we are again looking for A5. This A5, we are looking that it should be at least more than 35 mm of amplitude. So this is how it looks. So over here, when we see that normally the amplitude should be above 40, here the amplitude is 21. So in such case, we understand that the problem lies towards the platelet. So one pooled platelet, that is one SDP, if we could give, it would be helpful for the patient. Then third point is the uh, EXTEMCT, which talks about the coagulation time. If the coagulation time, the CT, over here what we look at, if this is more than 90 seconds, then there is a need to give FFP, 4 FFPs to the patient. And what we can do is, whenever we give this drug, after 10 minutes, we need to restart it again and we need to check that has it been useful to the patient. It is useful, but again, it is time consuming. Second, they noted that, okay, not many people could evaluate it properly. And at few cases, it has shown excess. And then it is really useful not only for trauma patients, but even for obstetric patients. It is really useful when we pre as in the area such like rural area. Okay. So coming back that ROTEM, this was all about ROTEM. Now we learned that, okay, when we are giving too much of blood, so our whole system, which we call lethal triad, then learned that, okay, we are giving massive blood transfusion. This lethal triad is changed to lethal diamond. First, let's talk diamond. The fourth factor has been added, okay, which is calcium. First thing what we need to know is what is lethal triad. So the lethal triad, it is all about coagulopathy, acidosis, hypothermia. And it's a vicious circle. We all are aware about it. That okay, one thing leads to the other, and ultimately it keeps on going in. Especially like hemorrhage, it reduces the circulatory volume and consumes clotting factor, which impedes the coagulation, worse bleeding, and further reducing volume and inhibits cellular perfusion, leading to acidosis and hypothermia. Thus, coagulopathy is worsened by the dilutional effects of the crystalloid fluid that we are giving. Now, talking about hypoxia. So, hypoxemia, poor perfusion and hypoxemia results from reduced circulatory volume and reduced oxygen carrying capacity. which ends up into anaerobic metabolism, which further leads to metabolic acidosis. Now, this acidosis directly impairs the clotting factor, which worsens the coagulopathy. Due to acidosis, it limits the endogenous heat, which leads to hypothermia. Hypothermia per se worsens perfusion, thus aggravates anaerobic metabolism and subsequently acidosis. Similarly, the anaerobic metabolism reduces the endogenous heat production has been reduced, so which leads to hypothermia. And hypothermia in this, it impairs enzymatic functions, leads to coagulopathy. Now, when we are giving too much hemorrhage, stage 3 and stage 4, hemorrhagic oxygen give transfusions and weight. Calcium also plays a major role, which was missed by multiple people, and then this lethal triad now changed to lethal diamond. Here, what they want to say is hypothermia causes decrease in liver metabolism of citrate. As we know that all the blood products where there is a lot of additives, citrates are there, and this citrates, because it has not been metabolized due to hypothermia, leads to bind with calcium, leading to less calcium available in the blood. Level with lower pH, and lower pH prolongs clot formation. Again, coagulopathy, calcium in the plasma is necessary because it acts as a cofactor. We all know when we are trying to sit, calcium level goes low. This is in short all about since the past till now. Now I'm coming to my basic topic, that is the future of emergency medicine. Technologies that make patients the point of care. Till date, yes, we are doing it for the patient, but we are always diverted with maybe focus or maybe CT scan or maybe with the bloods. So here now we want to make patient as a point of care, and we are trying to achieve. The first thing what the newer concepts are, with the help of artificial intelligence for testing and capacity. So in Hungary, OZ is using an artificial intelligence for capacity and logistic allocations in its daily operations, with daily cases of about 3,000 patients and cars that cover over 40 million kilometers each year. Their operation created huge amount of data. By using smart algorithm, they can use this data for prediction. What they want to say is artificial intelligence does not know that there will be an accident tomorrow or afternoon on a major two-lane road between two cities, but they can predict the statistical probabilities of that. So here there was also another software company, Hexagon, which also presented their artificial intelligence for emergency service in 2020, and their concept showed that a smart advisor system uses real-time operational data to find patterns and recognize major events as they occur. So what they want to say is, in India, if we also bring this concept, we understand where major accidents occur, at what time. There are days when in trauma, we are more doctors than patients, especially in the morning. Whereas in the evening, happens that doctors are less, patients are more. We learned this. So we reduced our time. Like in morning, only one doctor will take care. Evening, we need more doctors. And thus, the duties have been shared more towards the evening so that the patient care can be given. Similarly, this part has been taken care. And they noted that when this accident occurs, at what time. So based on that, they can keep ambulance services next to it. They can keep helicopters ready. They can even plan to keep a hospital nearby. They can alert. These are the whole benefits. So there are other ways, which is like apps. There are streamingly, like we can use it for the emergency medicine department. Now we all know that there are a lot of medical errors. Till date, if I want to read one ECG, I'm pretty sure that I will be disturbed at least 3 or 4 times just by, even if I'm reading an ECG, 3 to 4 staff, or there would be phone calls, there would be some patients, relatives who would be coming and they would be disturbing. So there is a chance of medical error. And this miscommunication is majorly between us. So to reduce this, there are newer concepts, newer software programs have been developed. One of them is Pulsara, which is very much used in like US. And this Pulsara is a developer based in Montana in the US. It created a HIPAA compliant platform for emergency medicine services, emergencies, and ambulance management. It has connect it has a connected mobile application that gives paramedic the power alert an emergency medicine department before patient arrives to the hospital. So it sends this alert not only the time, but can also share the conditions about the patient. So when they are sharing the condition, the part, the initial 15 minutes or maybe 5-10 minutes time what we are taking care, that part can be reduced by knowing that, okay, what is the condition, what is the history, what are the major chances, and things can be made available. This is how they had planned. And finally, when they had used it, it did show almost 30% reduction in the time for the treatment. So if I'm prior aware that I am going to receive a patient who has a polytrauma where massive blood transfusion is required and other investigations are required, his conditions is unstable. 1 liter of fluid has already been given. So that gives me a hint prior that, okay, in next 5 or 10 minutes, I'm going to receive such patient. Please get one O negative if it's a female, O positive blood if it's a male, at least uncross-matched blood, so that we can start the treatment. This will do. Again, CT scans can be kept empty for such patients. If it's a stroke patient, not only for trauma, it is also been used actually for MI cases, for stroke cases, where we always say that, okay, time is muscle, time is neuron, time is everything. So here, this benefits can be used. And Pulsara has been really very useful and it is widely used in US. There's also one app called Swiss City, which was introduced in Hungary and which uses the potentially life-saving method. So it's an app, and when we register, we are registering it as a volunteer. So if there is any cardiac arrest nearby, it alerts the volunteer. So those who are 500 meters around the incident area, they can hop in, and they can help. With this, they noted that there is almost double increase in the like successful rate over 1 year in CPR. So if there's a death or there's an accident which has occurred around 500 meters nearby, and if I am a volunteer, I would receive a message. Based on that message, if I'm free, I can go. Similarly, there will be so many people, and then due to more number of trained members, it helps, and the success was already been. Another app called as Full Code Pro. This was launched by American Heart Association, This app is a real-time CPR event in I'm pretty sure most of the time when we give CPR, especially in the rural area, the number of doctors are less, or I would say the trained doctors are less. There are more patients, so we have to divert our work. Ultimately, we end up losing less number of patients, less number of members. So though ACL is always say that okay, we need to have one CPR coach, we need to have one recorder, someone who can manage the time. In real life, we are not able to do it. But this app really works well. So once we see this patient, the first responder can start that, and it will help as a countdown as well. It can even tell you that okay, 2 minutes are up, you need to switch, you need to check files, you need to check the once comes to that okay, 4 minutes are there. There's a time to give the last epinephrine was given 4 minutes prior. Tell you the best compression, the ratio. So the time part, which mostly missed. We do our best, but still, if you say we are not always accurate, but if a machine guides you, it helps. And then everyone is in the same page. So ultimately, here patient becomes a primary focus rather than us documenting something or waiting. One who's looking at the watch so that jump for the CPR. Lot of stuff can be reduced. Then there are also video games for practice. Now, as a first year, when I had joined, I always found it difficult. Though Sandeep sir was always there. But when you are the first year patient, you always have something in the mind. Be able to favor, write something, what will happen to the patient? This initial part in the first year, I have faced it. But thanks to such games, which is quite useful, like intubations. So over here, they had made a game which was called as Level EX, a Chicago-based startup, which created a mobile video game that trains healthcare professionals. They created an Airway X EX app, which gives paramedic and doctor realistic scenarios to better prepare them for the challenges of airway management. Now, in a real life, when we have to put a tube, when we are doing it for the first time, it's difficult. The hands would be shaking, everything. Okay, am I doing it correct? The drug dose and all. This same part, if we do regularly, similar to as a skill demonstrations in the skill lab, what we are doing it regularly when you use playing these games and you learn with the different scenarios. Ultimately, you can learn all things. So sometimes you can even be outside enjoying the holidays at Maldives, but you're still learning. You can use this app just for 30 minutes or so. Maybe you can clear 2, 3 case scenarios, and then this game app will also give you a feedback that where did we miss something, or what better things could have been done, how much time did we take to intubate a patient. Lot of benefit. The last part is a portable point of care diagnostic unit. We all are aware that yes, if there is an ECG at home, it is useful. We started making. We know that it's there in the Apple phone. But again, we learned that, okay, just seeing one lead will not explain us that, okay, maybe I'm just seeing at the lead one, but MI is an inferior wall. So it's not gonna show. So here there was a app where they discovered a Smart Health Pro. It's a new app. And here they let the user see a 12 lead ECG. Thus, the benefit is without coming to the hospital, maybe the ambulance itself, we have this benefit, and wirelessly we get a tablet.
A 12 lead ECG will always be much better than one lead ECG. And such are the benefits of point of care, which we can even carry it now in our ambulance. Then there is a pre-hospital imaging. Any patients where a paramedics is going on and then they say that, okay, there is traumatic head injury because of the raccoon's eye, or patient is bleeding from his ear or from the nose, or there is a battle door, multiple. So a pre-hospital imaging can also be done, and that will also help alert the neurosurgeons so that they are available at the doorstep and things can be faster. Medical drones for delivering care from the air. We all are aware due to COVID, we all learned all these techniques and it has really helped a lot. So I'm not going to talk a lot. Then easing the transportation and the era of driverless ambulance. Now here, mm, I have been going for the ambulance calls since my first year. We do have that person who helps that, okay, we are bringing the space, cannot people. And now if I have to give CPR in the ambulance, I can't use my driver. He would be driving. So this benefit of driverless ambulance would ease a lot of stuff, and we can now focus on the patient. So the driverless cars are really useful. These are all hi-fi things, but these are still going on. These are the things which have been there. So I would like to say that the use of digital technologies can help patients get care faster and more efficiently. However, they can also give support to emergency care units in handling scenarios more confidently and safer while we are doing it with the games and other demonstrations, a lot of stuff. The emergencies of the future looks more database, efficient, streamlined, and quicker than ever before, while considering the limitations of caregiver and ensuring the need of the patient. Hopefully, within a few years, there will be a lower wait time and we could give proper care to the patient. Thank you.